we'll let you pull your slides up and everyone to get settled in. We're really excited for this afternoon's talk and grateful for everyone taking some time to be with us. I'll just briefly mention for folks who aren't familiar that we're the Maryland Addiction Consultation Service. We're grateful to have an hour of your time today. We won't take much time to orient you to what we do, but we are always happy to have you join us for these educational opportunities, which we offer here online and are happy to also provide to your practice or community. So feel free to reach out. Marcial will put information in the chat throughout the afternoon. So feel free to ask questions or engage there. We also provide warm line consultation to prescribers, healthcare practices, and pharmacists across the state. So if you have questions beyond what Dr. Ramprasad is able to answer today on the webinar, you can always call us at our toll-free number, and we're happy to engage with you or your teams throughout the week and beyond. So look for information about that in the chat as well. I will just very briefly introduce our speaker today, and I can let him expand certainly beyond, but we are grateful to have Dr. Ramprasad as a Max consultant. He also is a faculty member at the University of Maryland School of Medicine in the Department of Psychiatry, Division of Addiction Research and Treatment at the University of Maryland School of Medicine. He studied at New York University and then went on to get his medical degree at SUNY Upstate New York Medical School and has trained here in Maryland, where he did his residency and his addiction psychiatry fellowship. He is a faculty member and heavily involved in medical education and training. He is a member of the American Medical Association and Psychiatry Association. He has won awards. Probably I won't cover them all or talk about the depth and breadth of his clinical practice, but the George Bayless Award for Excellence in Medical Student Education, the Donald Ross Award for Outstanding Psychotherapy paper. He contributes across the clinical research and academic training efforts here at the School of Medicine in the Department of Psychiatry and is a Max consultant. We're really excited to hear Dr. Ramprasad talk today about medications for alcohol use disorder and to answer questions you might have about providing care across your clinical practice. So I'm going to turn it over now.
Okay, thank you, Kelly, for the very nice introduction. I appreciate it. So like she said, we were going to be talking about alcohol use disorder today and touching on the medications that are approved and also the issue of co-occurring disorders. Again, me as an addiction psychiatrist, I feel like that is what I'm running into, seeing quite a bit. And so we will touch on various diagnoses. I don't have any particular uh, super pearls of wisdom, but I do think it will be a good thing to kind of review where the comorbidity lies and how do we kind of address patients and how do we also think about medications when we are seeing patients with different comorbid conditions. So people are introducing themselves in the chat. I appreciate you guys being here. Let me share my slides. Max, not this one. Where is it? Uh, Not the echo one. Okay. Okay, can people see the slides okay? Or is that like zoomed in enough and large enough fonts? Hopefully.
I'm not
Feel free
sure.
to just go ahead.
Sorry, I'm not sure we're seeing the presenter view because we can see the small thumbnails on the one side.
Oh yeah, is this
There we go. That's great.
there we go.
Thank you.
Okay. All right. Please feel free to unmute if you guys have questions or cases that come up. I'm happy to spend some time on it. I tried not to pack in the slides too much, but if you guys have questions, please just unmute and let me know. We can talk about cases or anything else that comes to mind. So let me move people away from the text. Okay. So again, like I said, we're covering alcohol use disorder, pharmacologic treatments, various pitfalls depending on the patients, and also co-occurring disorders. So that is my information. Please feel free to reach out to the Max team or to myself if you guys have any follow-up issues. So Going on to some objectives for today, we are going to define alcohol use disorder to understand what are recommended daily and weekly drink limits. We're going to be able to list the only three FDA approved medications for alcohol use disorder and the relative indications, contraindications. Sorry, I am trying to move this off of my text. And then we will also be discussing again co-occurring disorders, how to understand these in the context of alcohol use, and how these things basically perpetuate each other. Uh, Sorry for the back and forth clicking here. Okay, let's go with this for now. All right, I also can't see everyone else who is on the screen once I hit play, so hopefully this is okay. All right. So when we talk about alcohol use disorder and determining whether it is a use disorder or just alcohol dependence, right, we were going to also discuss what is a standard drink. And so a standard drink, I grew up in New York. My like license and driving, permit test included a lot of this. And so what is a standard drink? Generally, we equate, one 5% beer, I should say, or 12-ounce 5% beer is equal to a 5-ounce glass of regular table wine, again, estimated around 12 or 17%, is equivalent to a 1.5-ounce shot of hard liquor like tequila, gin, whiskey, etc. Right. And so you guys can see the equivalences here. And so we're really talking about one, 100% pure ethanol, a 0.6-ounce drink is really what we classify as one drink. So again, depending on what the beverages of choice are amongst people you may be meeting, that is something to consider. And so, what is a standard drink? Again, this picture shows that is not a standard drink, right? And so, again, people will buy alcohol on their own, have it in their house. A home pour of wine may very well be the entire, giant goblet wine glass, right? Versus, what is an actual technical one drink is really only 5 ounces of wine. So really like a wine bottle should be about 4 to 5 total drinks versus, say you're pouring it at home and you have these giant glasses, maybe that's only two, but that's not really two drinks, right? So again, always ask what people mean by a drink. Oh, I have two drinks a day. How big are these drinks? Are you pouring them at home? Are you buying them every day? Right? Those things can matter as far as trying to ascertain like how much alcohol people are actually ingesting every day. So again, this table is kind of pointing out the same thing. I like that I kept this one also because it has names of specific drinks. And again, I'm not entirely sure everyone is practicing. It sounds like all over the state, but we have a lot of people in downtown Baltimore who kind of use these by name. I drink Steel Reserve. I drink, Mad Dog. And I'm like, well, I have to go look it up to see what that drink actually represents. And so again, people will kind of use the colloquialism I think very generously, and I think it's up to us sometimes to kind of figure what they mean by that. And so again, you guys can see at the bottom too. Again, there's a lot of like kind of labels and titles for these, right? So a fifth of what? Is it a pint? Is it a true pint bottle? Is it a fifth bottle, a handle, right? And all these things are different amounts, and they do equate to different numbers of drinks. So again, trying to get into the weeds sometimes can be helpful for patients when you don't exactly know how much they may be drinking. And so again, alcohol quantity here, how many shots are in a bottle. I got this picture from Google, right? So all these pictures I think do help explain what do people mean when they buy, a fifth, which is typically like a 750 mil bottle, right? That's typically you can see on the right side about 16 shots. When people talk about buying a handle bottle, right, that is also you can see on the bottom there about like 40 shots. And so again, a lot of names, terms, and again, I think it's also a little skewed because America does not work on the metric system, and so we're not talking about mils and liters all the time. We're also talking about ounces, fluid ounces, right? And so those are also things that may come into play again, depending on the person in question. And so I sometimes have people just gesture how big of a bottle, they have, two beers a day. I'm like, do you mean the regular 12-ounce cans or you mean the tall cans? And again, some people just are, it's easier for them to express it with their hands. And I'm okay with trying to estimate that as best as we can. And so these things, again, just to say, patients will kind of explain these in a lot of different words and different terms. And so, levels of risk for alcohol use disorder. So, generally, the recommendation, according to NIH, is that men should not be having more than 14 drinks a week, or more than four drinks on occasion. Kind of on the other side for women, generally not more than 7 drinks. I've seen 11 listed in some places, but generally like not more than 7 or 11 drinks a week for women. And again, the kind of binge episode drinking is really more than 4 for men and then more than 3 for women in one sitting. Right. And then, of course, for the elderly folks or geriatric patients, right, we may want to consider that the limits are going to be much less. Sorry, again, let me try to move this somewhere better. Uh, okay, so again, asking about drinks and how many and all of that can also help us kind of determine what level of physical dependence people may have, and also maybe if there's questions about medication managed withdrawal, that can be something we can look at too. And so, why are people drinking, right? Drinking does help us feel more relaxed. It does help with certain kind of mood aspects, anxiety aspects. People just want to have fun, which is also a fair, reason. So this table kind of lists the BAC percentages of blood alcohol concentration versus the effects that people typically tend to feel at those, quote, doses of alcohol. And so you can see the zero point zero 0.02, zero point zero 0.03 range typically tends to be mood elevation, maybe some muscle relaxation. Again, even like, say upon the second drink, the alcohol concentration is going up. People may feel relaxation, warmth, maybe an increase in reaction time, or they feel like they're paying attention to their surroundings like a little bit more than they would before. This is where we start to see decreased fine muscle coordination. Again, the zero point zero 0.08 limit is really where we make the cutoff for driving, but this is also where we see the issues of impaired balance, speech, vision, hearing, general coordination. Again, there's still some euphoria at that kind of level. And then once we go beyond that, you can see 0.14, 15, and above. We start to see more of the intoxication picture with alcohol. So slurred speech, ataxia, impaired motor function. Again, these concentrations also probably should be taken with a grain of salt. If someone has a very high tolerance to alcohol, right, this kind of table may shift down. So they may only start getting mood elevation at the legal limit zero point zero 0.08 as opposed to getting it at like a very early amount. And so, again, thinking of how long patients have been drinking can be useful. But you guys can see basically it becomes more severe as we go down in blood, as we go up in blood alcohol concentration. So we start to get confusion, hypotension, people being unconscious, people passing out, people report blackouts. I don't remember what happened that night. Really severe alcohol, almost poisoning at this point is respiratory depression, coma, and potential death. And so again, some patients who have very high tolerances may not be reaching these kind of severe consequences, but at the same time, we do have to also ask about what the history of alcohol use has been. And so, briefly about pharmacokinetics, maybe most people are familiar that blood alcohol tends to decrease just based on time, right? And so this is what we call zero order kinetics. So you can see basically it is just a function of time. We will decrease or process again depending on everyone's constitutional makeup and their liver functioning and all of that. We tend to decrease blood alcohol concentration over time in a kind of very linear manner. Um, and then it becomes first order below 10 milligrams per deciliter. But I feel like we're not typically seeing patients who are at this kind of like very early level of intoxication. So again, really, there's not much to do to speed up the metabolism of alcohol. This just kind of tends to happen over time. And again, really does depend on people's kind of metabolic function, their liver functioning. So the prevalence of alcohol misuse in primary care. I didn't get to see everyone's introductions. I'm sure there's some folks who work in primary care here. Uh, so I just put up this little pyramid. This is from an old study, but generally this is from what, 1998. So, again, the bottom 60% or so of patients are really either abstaining or very low risk drinking. I just drink for New Year's Eve or I drink for my birthday, and that's that. The top two are the ones we should be worrying about, right? So at-risk drinking, which has been variably defined, I think, over the time and years, and then alcohol use disorder formally, right? So we were really looking at the top two as far as patients that we're concerned about. And I would venture that this has changed since COVID. I mean, there's a lot of info and data out there that since COVID, alcohol sales have gone up, alcohol deliveries have gone up, people are generally drinking more. And so I venture that these numbers are a little bit skewed more towards the top of the pyramid these days. And so primary screening, we're not getting into a whole lot of clinical evaluation per se here, but the primary screen really is just to ask people, how often did you have a drink, an alcoholic drink, even beer or wine? And for some of my patients here in the city, we definitely have to specify that beer and wine count. But basically, how often do you have a drink with alcohol in the past year? You can follow up with that. How many drinks do you have on a typical day when you do drink, right? So trying to determine binge episodes. So do you, chug the whole bottle in one sitting and then you don't drink again for 2 weeks? Or is it that you stretch it out and you have a little bit every day for a few weeks, right? These are kind of different patterns of drinking that, again, maybe, differently, like clinically relevant. And then again, looking at binge drinking, how often did you have? Should be 4 and 3. How much? How often did you have 4 drinks for men, 3 drinks for women, elderly? And so again, these can just be ways to open up the conversation. And I do think oftentimes patients are hopefully willing to share other details of their drinking habits. So alcohol use disorder, right, formally is this list of 11 symptoms that is in the DSM. Basically, to have mild alcohol use disorder, you need to have 2 or 3 of these symptoms, which honestly sometimes comes along very easily. Again, moderate alcohol use disorder is 4 to 5, and then more than six of this list will qualify for severe alcohol use disorder. So just to go through them really fast, alcohol is generally taken in larger amounts or over a longer period of time than was intended. There are efforts to quit, but it's were unsuccessful. A great deal of time is spent, acquiring alcohol, using alcohol, recovering from the hangovers, and a lot of time is basically spent drinking or recovering from drinking, right? And so that's always a big one. And so a lot of these are very similar to any other substance use disorder criteria you guys will see in the DSM. And so a lot of these things you can substitute alcohol for kind of any other drug, and the criteria end up mostly being similar. And so will experience cravings or strong desires to use alcohol, recurrent use in the uh, resulting in the failure of major role obligations not being met, continued use despite having social interpersonal issues, important activities or social obligations are given up because of alcohol use. Recurrent alcohol use in situations where it's hazardous. So people who've had, DUIs or something in the past still are drinking and still driving, even though something terrible happened before. Again, that can be sometimes a marker of a use disorder. Alcohol use is continued despite knowledge of it being bad for you, right? Basically. And so if people have already been talked to about it, they've already considered quitting, but they still cannot seem to put it down. That is another criteria. And then the last two, I think, again, go along with a lot of the other substance use disorder criteria, is that tolerance and withdrawal. The tolerance being you need more and more alcohol to achieve that desired level of effect. Or if you continue to use the same amount, you have a markedly diminished effect. And then withdrawal being uh, characteristic withdrawal syndrome for alcohol. Again, it tends to be really the opposite of alcohol use. Alcohol makes you relaxed. Uh, without alcohol, you feel a little bit more anxious. Same on the sign for vital signs, right? If alcohol kind of reduces heart rate or kind of lowers your blood pressure, and the immediate effects, right? The opposite will be to have some rebound hypertension or rebound tachycardia. And so alcohol or a closely related substance like benzos, which they do overlap quite a bit, either are taken to avoid or relieve withdrawal symptoms. So that is the criteria for alcohol use disorder. And again, I think oftentimes we don't have to ask all of these 11 points to really formulate a diagnosis. I include some other interesting points here about alcohol use disorder, in that alcohol use disorder can present as similar phenotypes in certain individuals, but the disease state may have been arrived through very different trajectories. So you can see on this chart, right, over time, uh, on the y-axis is severity of environmental triggers. So you can see someone who's had like a very large amount of environmental triggers in the past, right, may easily kind of slide down this route for, again, various reasons, slide down into the route of alcohol use disorder. Whereas somebody who's had like less environmental stressors or triggers, right, can easily also kind of arrive in this disease state over the course of years. And so types of alcoholism, I will go through here. There's this really old study from 1992 by Thomas Babor, And he described two types of alcohol use disorder or alcohol dependence or alcoholism, if you will. And so type A was folks who kind of had a later onset of their alcohol use, so generally after 25. They tend to have less severe dependence, less childhood risk factors, less psychiatric comorbidity, versus type B, where we tend to see increased familial rates or family history of alcohol use, increased polysubstance use, generally a younger age of onset. So people tend to start drinking before 25, and then just generally greater comorbidity with cluster B psychopathology, and I would venture all other types of psychopathology. And so these are ways to kind of just think about drinking and kind of when does it come up? What age are you meeting your patient? What led them to such current like situation? And so again, this kind of breakdown type A and B sometimes can be useful to think about. And they say genetic factors account for about 50 or 60% of disease risk in alcohol use disorder. And so this little chart is also saying 60%. And so you will see a lot of kind of genetic concordance, family concordance with alcohol use disorder. There's about a 3 or 4 time higher risk in close relatives of people with AUD who will actually then develop AUD themselves. The greater number of affected relatives, closer genetic relationships. So again, a lot of first degree relatives with this. You know, you may see this with your patients as well. Severity of the related problems in affected relatives. So again, more severe use in a related person may also, kind of dictate or speak to the risk you're seeing with your patient. So they've done all the kind of twin studies, and again, there seems to be kind of higher risk in that. And then they did some studies of adopted children. There's about a 3 or 4 times increased risk in adopted children who have a biological parent who's alcohol dependent. So even though they're raised by a family that does not drink, right, they still may be very well at risk for alcohol dependence or use disorder. So not to go too much in the weeds with this diagram, but basically I included this just to show that there are a variety of effects with alcohol on different reward systems, right? And so again, this is looking kind of primarily at the ventral tegmental area, nucleus accumbens. This is really like a lot of our reward system. And you can see this picture lists some other drugs of abuse as well, like cannabinoids, opiates, nicotine, right? And so alcohol kind of being a more of a GABA agent, right? Where does that play in? And also, we will talk a little bit about what the reward systems are like for alcohol and how we can kind of hopefully intervene on those to help prevent, further dependence or worsening of dependence or use disorder. So I broke these down. Typically, what we think about as far as the experience of alcohol, and so some neuropharmacology here. And so, as far as the euphoria and pleasure, right, or even the second bullet point of as far as anxiolysis, right, the GABA, the increased GABA tone that we get from alcohol can help relieve anxiety, right? We're kind of calming down our body, GABA being an inhibitory neurotransmitter. A lot of the euphoria and pleasure does come from dopamine, much like any other substance of abuse. And there also tends to be a component of like the endorphin system, and which we'll get to when we talk about naltrexone. But there tends to be an endorphin release too when people are having fun drinking, right? And that is what ideally naltrexone will seek to target. You guys can see some other receptor activities here that are involved. So, albeit, I think needless to say, there are a lot of different receptor activities. Alcohol is not just a kind of strictly GABA agent, but it does kind of impinge on some other systems, which we will get to. So the three, sorry, let me get this back up again. So the medications for alcohol use disorder are disulfiram, which is known as antabuse, naltrexone, also known as Revia. Then we also have the long-acting injectable form known as Vivitrol, and then we have a camprosate, which is Camprel. And so those are the three formerly FDA-approved medications for alcohol use disorder. You can see on the right side, there is a long list of other agents that we have attempted to try, and there have been small studies, no studies, just thoughts about if this would impact the pathway of alcohol reward. And so one of our former chairmen here in Maryland actually did some research looking at ondansetron and trying to modulate this kind of serotonin balance. And so looking at ondansetron to help with alcohol use or dependence. Calcium carbamide, which is another acetaldehyde dehydrogenase inhibitor. Gabapentin, I would also add on here. pregabalin or Lyrica, right, have been, I think, increasingly used these days. They're not directly GABAergic medications, but there have been some things looking at that. Topiramate has been another one we've tried a lot in clinic, and again, very kind of varied receptor actions with topiramate, and so not entirely sure which of those is helping, but sometimes that's been looked at. Uh, Tiapride, that's a medicine not approved in the US, but is approved in Europe. There's been some studies looking at that as a dopamine 2 and 3 receptor antagonist. The people have looked at varenicline, which is typically used for smoking cessation. Again, if we can modulate some of these kind of acetylcholinergic pathways, is that worth looking at? Some studies lately have been looking at psilocybin, oxytocin. I actually just read something this past week about semaglutide. There was a study for alcohol use disorder. I'm guessing the other GLP-1 agents may be considered in the future. So as much as people use, Ozempic for weight loss, I think there's been some pretty interesting stuff coming about with semaglutide for various addiction issues and cravings. So again, all of those to be said, experimental, still in the works, still in research, but really those three are the ones we'll focus on today. And so disulfiram again. Sorry, this screen is messing me up here. Disulfiram, again, was the first medicine approved for alcohol use disorder, approved in 1951. I put this little picture from Google because I think it just kind of lays out the pathway of alcohol metabolism. And so you guys can see alcohol typically goes through alcohol dehydrogenase. It becomes acetaldehyde, and then acetaldehyde then has to be processed by our bodies too with aldehyde dehydrogenase. And so disulfiram inhibits that second enzyme, aldehyde dehydrogenase. It is an irreversible binder. It does inhibit that enzyme and causes the buildup of acetaldehyde in their body. So once someone were to drink on disulfiram, the acetaldehyde buildup, since we're kind of blocking this pathway, right? Once the acetaldehyde builds up, people tend to have nausea, flushing, dizziness, headaches, blood pressure issues, headaches, dizziness, etc. So uh, all that to say, disulfiram does not actually affect like the opioid system or endogenous opioid system. It does not affect GABA or glutamate. It does have some minor effects on the dopamine beta hydroxylase enzyme, which can affect serotonin and dopamine balance, but typically uh, not something we think about a whole lot. And so, really, antabuse by causing this buildup of acetaldehyde is really leading to a aversive conditioning state. So if someone were to drink on this medicine, they start to feel very sick, and ideally they will not want to be drinking after that. And so really the aversive conditioning principle is what really is the useful part for disulfiram. And so there's some side effects to consider here. There are some risks of hepatotoxicity. There are risks of some neurologic issues. I have not come across this in my own clinical practice. I also never really kind of pushed the dose much higher than 250 or rarely 500. But generally, we are keeping the doses fairly low. So again, some neurologic things can be drowsiness, lethargy, peripheral neuropathy in very rare cases. It is completely metabolized by the liver, and according to the American College of GI, Gastroenterology, we should not be using antabuse in anybody with serious liver issues, which is something we will maybe encounter with people with substance use. Maybe they have hepatitis, or maybe they do have alcoholic cirrhosis or liver issues from that. And so this can sometimes be a contraindication. And we also want to consider the fact that it is metabolized in the liver. We may want to consider like the CYP enzymes and other drug-drug interactions, depending on others, other folks' med regimens, if there are other many or a lot of liver metabolized agents, maybe that also shifts our risk benefit analysis. There's another contraindication for CHF and coronary artery disease. Go ahead.
Sorry, Dr. Ramprasad, before you get too far, a question popped in the chat, and I don't know
Oh,
if you
thanks.
want to save that or take a look at it now.
I can
I
try to
can
look at it,
I can tee
or
it
you
up
can.
for you. Yeah. The question is, how do you evaluate current evidence about the potential of GLP-1 receptor agonists for AUD? And are they close, or is it close to being a candidate for the toolkit?
That is a good question. I don't know if it's close to being used in the toolkit yet, but I do think it's kind of an interesting, different mechanism, medication that we can consider. And I think, all the GLP ones I think are fairly new. I mean, even for diabetes and for weight loss and all these things, we haven't just really seen a length of time to really know what long-term side effects may be like. So I suspect, again, there's a lot of interesting talks about how these things impact cravings or addiction behaviors for that matter. So I'm guessing hopefully people will continue to look at it, but I don't think it's necessarily on the pipeline to be like approved for substance use disorder or alcohol for that matter. So good question though. I mean, these are very interesting, I think, agents, and I think we are looking kind of beyond the usual monoamines, beyond the usual pathways of alcohol. And so I don't see why not, at least not yet. But I think we're probably all waiting for some better data. Yeah.
Thank you.
I can always forward the article I read this week, but there is a lot looking at these GLP ones, and so sometimes I think, at least for now, maybe out of interest, but later on, who's to say these things won't kind of prove themselves worthy? So, okay. Um, let's see. Okay, so that is also I lost all you guys here. Let me go back to the display. I don't think I can see the chat or see you guys while I'm sharing this, but anyway, we will go on. And so for disulfiram, some other kind of like clinical pearls, I guess. It helps to abstain from alcohol for 12 hours at least before starting it, and also to avoid alcohol for at least 14 days after stopping the medicine. So again, it's an irreversible binder of the aldehyde dehydrogenase enzyme, and so really by the time people are taking disulfiram, they stop it. By the time your body starts to manufacture the enzyme again, will take up to 2 weeks. So there's reports of disulfiram reactions happening out to at least 2 weeks after people have stopped taking it. And so you always want to kind of have a good window of alcohol abstinence before you start or stop this medicine. There tends to be no benefits to going beyond 500 milligrams a day. I typically just use the 250 milligram tablet that is available. Sometimes I will tell people to split it in half. Again, you may want to consider dose changes depending, on the population. So if it's elderly folks, maybe you want to worry about the severity of the reaction, which does somewhat tend to be dose dependent on disulfiram. And again, medical comorbidities. And so again, for people who are more medically frail, this may not the disulfiram reaction, again, we are looking for, but may also be hard to tolerate for some patients. So generally, it's best in a supervised setting with a program or a partner, spouse, family. And again, I've had patients say, like, I just knew I was going to drink today, so I didn't take the medicine today. I thought I wasn't going to get sick. And again, some people still will get sick. So again, supervision, I think, is very helpful. Ideally in a substance use treatment program, and then also to beware of a lot of other medications, over-the-counter things that can contain alcohol that we don't always think of. So the one, at least medication-wise, sertraline comes in mostly tablets. It does come in an oral solution that's about 12% alcohol. So if anybody is taking sertraline liquid formulation, alcohol is present in there and can trigger a disulfiram reaction. Over-the-counter cough medicines or really any over-the-counter kind of URI medications may contain some degree of alcohol. Vinegars, mouthwashes, different wine reductions, sauces and things, right? All these things can also trigger a reaction. I haven't had it come up too much with like topical use, but people have also said like aftershaves or things that have alcohol like that can also trigger a reaction. I tend to suspect that that's less so than kind of systemic absorption, drinking alcohol of some sort, but something else to be wary of. So again, wrap up points with disulfiram is that patients who are motivated for treatment really commit to total abstinence, right? Because the whole point of this is that whole aversive conditioning. So if you drink while you take this, you will feel very sick. Ideally, you will not want to be drinking again or trying that again. So again, commitment to total abstinence is helpful. Having supervised dose administration, whether that's family, support systems, programs people are at, and then hopefully someone who's able to understand the consequences of this drinking and the reaction they may get, and also they can participate in their treatment monitoring as far as getting labs or following up with that as they continue with their therapy. So we're going to go on to naltrexone, which is the second medication here. Naltrexone was approved in 1984 for moderate to severe alcohol use disorder. Like I said, it's available orally as a tablet, also as the long-acting injectable form known as Vivitrol. And so naltrexone, again, this is a very different mode of action. So this little picture kind of shows again our midbrain reward systems, ventral tegmental area and the nucleus accumbens. And so you guys can see where alcohol comes in, there tends to be an endorphin, beta endorphin release. And so the idea with naltrexone is that we were going to block that endorphin release from the alcohol and hopefully block the kind of subsequent, you know, neurotransmitter pathway. And so hopefully the idea being that people are not going to get the kind of same pleasure from the alcohol use and again may decide to wean down or drink less. And so the effects are really primarily about decreasing the reinforcement for alcohol. So this is one where if you drink while you take naltrexone, you're not going to get sick, right? But this is really that drinking basically won't feel as fun. You may not want to drink as much as usual. You may not drink every day. And the combined trial, which I can also send to you guys if you're interested, the combined trial is kind of a big trial looking at a lot of these medications for alcohol, both in by themselves and in combination, hence the name. Um, Combined trial found that with naltrexone, there was increased percentage days of abstinence, reduced risks of heavy drinking days, and what they kind of covered generally as good clinical outcomes. So no more than 2 days of heavy drinking a week and drinking below that 14 drinks a week limit. There's been some other kind of meta-analyses and a Cochrane review about naltrexone. It seems to be generally superior to placebo in preventing relapse and also increasing the amount of abstinent days. So naltrexone, I always think of as kind of a uh, good choice for people who are not looking for maybe, at least at this point, complete total abstinence, right? So this is not kind of aversive conditioning medicine. You can drink and take naltrexone. The idea being here, though, is that maybe you will pick up one less drink, three less drinks, or you won't drink every single day, right? So it's not going to be as reinforcing and it's not going to be as fun. Uh, Going back to that study from 92, but also in general, I think thinking about family history and who develops alcohol use disorder, again, we talked about kind of a high genetic risk with this, but it seemed like in one of these studies that they were looking at plasma endorphin release with alcohol use. And it seemed that the people who had a lot of family history of alcohol use disorder or alcohol dependence seemed to have more of this endorphin release. And so, again, the idea sometimes being that if we're detecting somebody who has alcohol use disorder or dependence, and they have a lot of family history, right? We can, again, maybe think about if the fact that they are getting more of an endorphin release from their drinking. And so maybe naltrexone would jump up our list of potential options to offer said patient. And so this is not always concrete, but it is kind of an interesting aspect. And I think it's just interesting to think about why do people drink at all, right? Some people drink for fun. It's just always really fun for them. Sometimes it's just a weekend celebratory thing. Sometimes people are drinking for anxiety relief. We'll get to comorbidities a little later, but are you drinking to relieve symptoms? Are you drinking to add something to your night out? So what are the reasons, right, why people drink? I think is something always to consider or even just ask patients. It may help in some sense shape decision making for your treatment. um, Same picture here again, but basically naltrexone is generally very well tolerated. The occasional nausea, headache, sedation, maybe anxiety. Some hypotheses as to, well, you are using an opioid blocker. And so to think of that on the converse, people use opioids and get certain effects. They get constipation, they get pain relief. Uh, Maybe it adds to the nausea sometimes for some folks, right? So on the opposite end with an opioid blocker, maybe you do have increased GI activity, maybe you have nausea, you have some sedation, maybe you have some anxiety. So it tends to be pretty mild overall. Very rarely described increases in liver function testing. Generally, it's contraindicated in those who have LFTs who are like more than three, four, five times the normal limits. But have not seen it kind of worsen liver function tests in my experience. And trials should typically go for about 3 months, 4 months. If the patient can maintain abstinence, you can always try to come off the naltrexone and see how they do. Some people just feel comfortable taking a medicine regardless of its effects, but they feel like that's kind of a fallback option, or they feel safe having something on board. And so I don't really fight people to get them off of it sooner, but minimum I would say probably 3 months. And then again with dosing, again, naltrexone comes in tablets. So you can start at 25. Typical dose we usually use is 50. You can push it to 100 milligrams. I haven't seen really too much difference, honestly, between all of the doses, but these are ways, again, maybe patients feel like, oh, a higher dose would help me out better, or they feel like it's going to act better. And I won't argue with placebo effect per se. And then again, this chart here shows so the yellow line is taking naltrexone tablets every day. So you can see a peak concentration, it comes back down. You take it the next day, it's up and down the entire time. The blue line is Vivitrol. So blue line is the long-acting injectable form of naltrexone. Comes in one dose, 380 milligrams. And you guys can see how the kinetics are a little bit more smoothed out using the monthly injection. So you do get this kind of burst of high concentration around day one, two, three, and then it tends to taper off towards the end of the month. Um, Otherwise, naltrexone tablets can be dosed once daily. Sometimes I have patients where this curve is a little shifted, right? So maybe the dose does wear off after 3 weeks. I've had some patients where I've done every 3 week injection instead of every month. Or maybe they feel like it's still working and you can push it out to every 5 weeks instead of every month. And so again, everyone's kinetics and metabolism will be a little bit different. And of course, naltrexone being an opioid blocker is contraindicated in those who are receiving opioids for chronic pain, or also anybody who is on any form of medication for opioid use disorder like methadone or Suboxone. And so you cannot have this coexist with those two. And so I work pretty much at a methadone clinic, and sometimes naltrexone is out the window just for those reasons, simply. So there are some contraindications or things to consider with naltrexone. I am minimizing this to see if there's other questions, but if not, I'll keep going on.
We do have two in the chat.
Okay, I will
One,
pause there.
okay, back to Dr. I'm sorry, to your dis disulfiram, if I have that right. Do you start patients on 250 or 500?
I will start at 250. I think pending medical frailty, I may tell them to just do a half and start with 125 and then see how it's tolerated and see how it goes. I think the tablets are 250 and 500 though. So 250 generally, again, if I'm like really wary or hesitant, I will do 125.
Thanks. And then a more general question, please feel free to unmute Jessica if I don't, if you had a more specific question. But this says generally, how long should someone stay on these medications? So it's not about a specific medication.
Yeah, I guess naltrexone had some about that, like usually 3 months. I don't know if there is a real timeline for how long people should stay. I like to think generally with what we do in addictions, if the medicine is still being helpful, then we should stick with it. I do respect people's interest or motivations to want to taper off or try to come down and see how it goes, right? So I think having some period of stability before we start to taper medications is probably helpful. So I would venture 3 to 6 months to try to continue people on and see how they do with it before you start to taper it off. I just generally think if people want to come off too soon, they may easily fall back into their old patterns they don't want to. And so I would say like 3 to 6 months probably for all of them. And then I think it'll always be a risk benefit ongoing discussion with your patient, right? Like, well, okay, you want to come down or you want to come off, let's try it and see how this month goes. If it doesn't go well, at least we know there's an option that we can fall back onto. And again, leveraging a lot of psychosocial therapies, treatment, counseling, IOPs, groups, whatever. I think all of those things can also help mitigate the risk of relapse. Say you did stop the medicine, but if they have appropriate supports in place, I do think that goes a long way. So no definitive answer for Miss Jessica, but I would say, yeah, if we have some period of stability, whether that's 3 or 6 months, I think that's probably a good time to at least have that conversation with patients and see what they think.
Thank you. Those are the two in the chat now, and I'll just maybe
Okay.
keep adding questions in the chat. We have about 15 minutes left, but if you save a few minutes,
Okay.
I'm happy to tee those up, or you can address them um,
Okay.
when you take a pause for questions at the end.
Okay.
Thank you.
Yeah, 15 minutes. Thank you. All right, so let's go through a camprosate and then we will get to some comorbidity discussion. So camprosate is the third medicine. It was approved in 2004. It's actually been approved in Europe for much longer than that. And so I think we are still a little bit Unclear what the exact mechanism is of acamprosate. It is an NMDA glutamate receptor modulator. It appears to have the effect to decrease cravings by normalizing the kind of GABA glutamate imbalance that comes with heavy drinking, right? So, um, generally people are drinking a lot. It's adding a lot of GABA inhibitory tone to their brain, right? Your brain is going to upregulate glutamate to be more excitatory. And so generally alcohol withdrawal has to do with this kind of upregulation of the glutamate, right? And so in some sense, acamprosate is trying to normalize the glutamate levels. And this can be an effective treatment, especially for those who have had some period of abstinence and then are looking to kind of maintain their abstinence. And so the common side effects for acamprosate are really not a whole lot. Mostly GI stuff, mostly nausea, sometimes diarrhea. There is or was a warning for increased suicide or violence, but it's not something that I've heard of very commonly. Acamprosate is totally kidney renally cleared, and so there is no liver toxicity. There's no contraindications with any liver disease or hepatitis or drug interactions, but it is contraindicated in kidney disease. And the dosing for acamprosate is 3 times a day. Interesting dosing pattern. It's 333 milligrams, uh, 2 tablets, so 666 milligrams 3 times a day. So very specific. It only comes in these like one dosing patterns. I have had poor luck with getting people to take a medicine 3 times a day, not just for substance use, but in general. And so TID dosing can be problematic. Some doses looked at consolidating it into twice a day dosing, which I guess could also work, but I have not tried that myself. So again, this is the only one where it is repeated dosing throughout the day. So 3 times a day or maybe twice a day if you push it. So I do think that does lend some level of non-adherence to medication, depending on the patient. Um, like I said, it generally is most helpful after some period of withdrawal. So usually 5 days after alcohol cessation, again, when the kind of glutamate GABA imbalance is really affecting folks, I think this is where acamprosate can be helpful. The most studies show effectiveness in maintaining abstinence from alcohol. So you can see with all three of these drugs, uh, they have different metrics as to how they have evaluated their efficacy, right? So antabuse was not drinking at all, total abstinence. Naltrexone is reducing drinking days or how many days until you relapse or days of abstinence, right? And acamprosate is maintaining abstinence, right? So all these kind of have different metrics as to why they're effective. And so you can continue taking acamprosate and naltrexone for that matter, even if somebody does relapse back to alcohol use. You don't get sick again. This is not the same aversive conditioning like disulfiram. And so it has been shown in some trials to be as effective as naltrexone, but hopefully some fewer adverse reactions. And you can consider the combination of those two if you felt fit. And so again, I'm going to go over this kind of quickly. Again, more effective than placebo in reducing drinking days, increasing complete abstinence, lengthening the time of abstinence or the time to relapse for that matter. Again, you can use the acamprosate with if people are on methadone or Suboxone. There tends to be no withdrawal syndrome from stopping acamprosate, so there's no real taper needed if people just stop. It generally tends to be okay. And so, really, lack of a lot of major side effects, definitely no liver effects, and very limited kind of drug-drug interactions. And so, it may be worth trying for patients who are also kind of on the fence about their recovery, or maybe want to try one thing and they're not really quite sure. This can be one to uh, we can vote for first. And again, with kind of low risks involved with at least trying it for a little while. All right, last 10 minutes, we're going to go over some things with alcohol and psychiatric comorbidity. Um, I would venture, I guess, the main point here as far as evaluation goes is that consider the onset and chronology of the symptoms. So only having symptoms like talkativeness or poor sleep or grandiosity, if it only happens during the drinking periods, right? That may help us rule out like a true bipolar spectrum disorder, let's say, right? And so you always want to kind of consider when are the symptoms happening in addition to when is the drinking happening. And if symptoms are happening outside of the drinking, maybe we have a less alcohol-induced mood picture or alcohol-induced anxiety picture, right? Maybe this is its own kind of separate disorder. And so the last bullet point, really summing up a lot of research, but you can see the wide range. About a quarter to three-quarters of patients with alcohol dependence have some type of anxiety or depressive disorders, also sometimes trauma disorders. And so again, it kind of goes bilaterally, right? So you can think of alcohol use as far as self-medication hypothesis, right? People are going to use alcohol to help with their panic attacks or help with their anxiety. And, that works in the short term, more than likely. But chronic alcohol intake will have the opposite effects, and people will have kind of rebound anxiety, rebound mood symptoms, and may actually worsen the course of the disease. Um, some studies have looked at, is alcohol use just a feature of major depression? Is that something that comes along with it, not just in the self-medication sense, but that people will be more prone to pick up drugs of abuse because of their mental state, right? So you can kind of go both ways, you guys can see. And then the prognosis for comorbid patients is generally more negative compared to those without alcohol use. So alcohol use can worsen psychiatric symptoms in general, increase their frequency, can prolong hospitalizations, prolong their response to medications. It can also just generally reduce life expectancy. And so this picture here about opponent process really gets at that point, right? So with the self-medication idea. And so you can say the curve is alcohol, right? So mood is at a baseline, you have a few drinks, mood is elevated, you're feeling good, things fall off, you are no longer intoxicated. Maybe your mood actually does go below the set point that you had before, right? And say you don't drink again for a while. Um, when you drink again, though, the mood benefits or the mood boost that you get may be less, and then the downslope and the rebound kind of phenomenon actually comes back a lot more. So people who are drinking every day kind of get into this cycle where you start to lose all the positive effects of alcohol. You stop having fun with it. It stops relieving your anxiety. But actually, now that your brain has upregulated all of these other drivers of anxiety or pain or depression, right? People start to kind of downslide into a point where alcohol no longer brings them to some middle set point, right? This is now becoming, drinking just to get by. Well, people will describe it as that, right? I'm drinking just to get by. It helps me get out of bed. It helps me relieve withdrawal. And you're not really getting any fun or benefits from it at any point later on. So again, depending on the person, depends how much they drink, depends on other things. But this process in this graph can, happen very quickly, honestly. And we do see this with like pretty much every other drug of abuse, right? Opioids help with pain, then they don't help with pain. And eventually there's some point where you're just taking opioids to not even have withdrawal. You're not even getting any pain relief or any euphoria or fun from it. And so we see this pretty much this cycle with kind of all drugs of abuse. I'm going to skip over this for sake of time. Basically, suffice to say, all these things are very much connected. So again, as much as we are picking apart certain mechanisms and certain neurotransmitters here today, all of these things are interwoven in different areas of our brain. Really fast to go through with depression and anxiety. About a quarter to maybe a half of folks with lifetime major depression has also, with alcohol use or maybe also meet criteria for major depression. Again, can go back and forth, right? Are you drinking to self-medicate, or does alcohol in itself lead to depression, right? And again, people colloquially say it's a downer. But alcohol can also lead to a variety of biological and social effects that can also um, lead to depression, right? So I think it does go both ways. Same thing with anxiety, right? Alcohol can help anxiety, but on the converse, maybe people are going to get into this kind of cycle we just talked about. Some quick things about medications. I guess we're not really using TCAs a whole lot these days. I've seen it very rarely. Again, TCAs are very risky and overdose. I do not prescribe these to patients who I think are drinking. Again, the very narrow therapeutic window. Are you dehydrating yourself when you drink? Are you going to have higher concentrations of the drug in your bloodstream? SSRIs are likely safer. There's not really a whole lot looking at SSRIs per se for like what it does to alcohol use. But again, if we can modulate depression or anxiety, those are probably worth it. There's a study looking at, or some studies looking at buspirone. Generally, buspirone reduces anxiety symptoms, but it seemed to not have too much effect for alcohol. Benzos, again, maybe obviously can be additive with alcohol. And so, again, unless you're using benzos to manage withdrawal within a 3 to 5 day kind of period, I do think benzos can have additive risk with alcohol intoxication. And TCAs like MAOIs, I don't use them a whole lot. MAOIs have all their food and beverage restrictions. There's a lot of monitoring that comes with it. And so generally, I avoid things like this with people who have more kind of unstable drinking. Um, Psychotherapy, I will just mention here very briefly. Really, all kinds of therapy can be useful. I am more inclined on the psychodynamic approach, but again, people want time-limited treatments like CBT. I think a lot of the apps that are out there these days kind of are very CBT focused. MI, motivational interviewing, motivational enhancement therapy, contingency management, these are all things to consider depending where you work and what your resources are. I will mention very quickly here ADHD. Uh, Again, I think this is coming up a lot more in patients' complaints to me, at least in my practice. And so alcohol use is prevalent in those with ADHD. And again, is alcohol settling down their very quick moving mind, or does ADHD confer a risk or increase risk of being chancier with your behaviors or being more engaged in risk-taking behaviors? And so again, is alcohol used self-medication wise, or is this alcohol use kind of a subsequent problem due to ADHD? So again, we see a lot of folks with ADHD in the substance use world. I do think it does predispose people to want to take more risks, or hey, what is that like? My friend did it. I want to try it. Right. And so again, I think there is a bilateral connection here with ADHD and alcohol use. I would throw out here too, if people are taking stimulants for their ADHD, you always want to know what other, potential medicines or alcohol or downers that they may be on. So again, with stimulants and alcohol, I see a lot of stimulant and benzo co-prescribing. I think stimulants and alcohol also carries its own risk there. And then with PTSD, um, I won't get into the study here, but again, it seems like this one kind of goes the other way, where people with PTSD may have increased risk of picking up, more drinking or alcohol dependence. And then at the same time, too, alcohol does put people at risk for, unsavory events, including sexual assault, victimization in different ways, aggravated assault, accidents, driving accidents. And so I think these do co-occur quite frequently, but sometimes it's interesting to ask patients how they felt. Which one was first? I used to drink a lot and then I was assaulted and now I have PTSD. Or there's other ones where I met veterans before at the VA where, they went to war, have this happen to them, and now alcohol is their means of coping. And so, again, the stories of patients will tell you sometimes it's helpful to flesh that out. So generally, I will wrap it up here. Alcohol use disorder co-occurs with a wide range of other psychiatric disorders. Again, bilateral pathway between these two, still something to be untangled and still a point of research. And then again, the key points for the alcohol use itself. We want to limit to less than 14 drinks weekly for men, less than 7 for women. Again, binge drinking episodes is another kind of metric you can look at. So how many drinks in one setting? And then also the 3 approved medications, disulfiram, naltrexone, acamprosate, each with differing types of actions and may actually be more suitable for one patient than another. Um, so I will end there. I have a lot of resources. I can send folks studies if you let me know.
Thank you so much. I appreciate that. I know we're right at the hour. There's one question in the chat. If folks have others, please drop them in. And if we are able to, we'll certainly get to them. I see a question for the end, Larry, and then you follow up. So if you have a second question, feel free to unmute and share that. But Larry Wise asks, is alcohol use disorder a brain disease? And then if you had a second question, please let us know.
I agree with the next comment. That's a doozy. It's probably its own lecture in itself, to be honest. I do think it is on some level, right, a brain disease. I do think, again, people drinking on a Friday night or just for celebratory things, that is different than people who are drinking, let's say, a pint or a fifth a day of alcohol, right? And I do think there are a lot of downstream neurobiological changes that do happen with alcohol use over a sustained heavy drinking period, right? So in that sense, brain or neurotransmitter disease, I would venture that that's true, right? Because again, if you look at all the medicines that we talked about today, right, we are looking to impinge on that cycle at some point downstream, right? So I would venture it is a brain disease. And again, our treatments are kind of looking at where can we modulate this perturbed cycle, right? Are we going to modulate the pleasure component of it? Are we going to modulate, this kind of aversive conditioning? Are we going to deal with the GABA glutamate imbalance? Are we going to deal with cravings in some sense, right? And so again, you can see like there's a lot of different ways to look at this cycle, and I'm guessing that does reflect it's kind of widespread brain changes, right? And again, sometimes we're looking at one system in isolation. These things do not really exist in isolation. So hope that answers very briefly.
Thank you so much for that. I don't see any other questions in the chat. I see some thank yous directed your way. So we
Cool.
will get ready to wrap up since we're at time. As Marcial indicated in the chat, the recording and the slides will be up on our website. Give us about a week for that. I see, a few more thank yous coming in. I was checking if that was questions. So feel free to reach out via our phone line or email if you have questions that weren't answered today. And then look for the slides and the recording to be added to our website. Thanks again. Thank you, Dr. Rampashad. This was wonderful and very informative. We appreciate you taking the time and for everyone joining us for this hour.
Sure.
Take care.
Appreciate the attention and all the good questions. Yeah, I can send the slides. I can send the articles as well if people are
Thank you.
interested
We
in
can
some
make
more
those
further
available.
reading. Yeah,
Yeah.
let me know, Kelly.
Yeah. Yeah. Feel free to send them and we'll share them.
Okay.
Thanks so much.
Thank you all.
Have a good afternoon. Bye-bye.